My name is Kelsey Arford. I work, I'm the founder and director of PAP Alliance, and we provide information for patients as well as support groups. And we also do webinars, which thank you for joining us. And so I would like to introduce my co-host. Her name is Jen Wesco, and let her introduce herself.
Hi, everyone. Just so happy that everyone is here this morning here on the Eastern Coast in the US. It's a pleasure to be part of this webinar co-hosting with Kelsey and PAP Alliance and help educating the community about PAP and bridging that connection with pulmonary fibrosis. I am the executive director of Wesco Foundation for Pulmonary Fibrosis. It lends very deeply in our organization as my dad had idiopathic pulmonary fibrosis. Our programming really leans into the supportive care aspect of the journey, as well as the educational component to it. It's really important for us also with the patient voice in clinical trials and design and development of it. And so we have this approach, a very wraparound approach, and it truly is an honor to be on this webinar and being together with Kelsey and Dr. McCarthy and everyone here. So thank you for being here, and I look forward to the next hour.
Great. Thanks so much, Jen. So just so everyone knows, we do have a Q&A at the bottom of the screen. If you have any questions that come up that you'd like us to answer, please submit them through there. We will have about 10 or 15 minutes at the end of this to go ahead and go through those. So please go ahead and submit those if you have any. And without further ado, I want to introduce our host of the meeting, Dr. McCarthy. And he will be sharing some slides with us. And so let's jump on in. Thanks so much, Dr. McCarthy.
Thanks, Kelsey. Sorry, just took a minute to unmute there. Yeah, thank you. I'm going to share my screen and I'm going to talk very briefly just about pulmonary alveolar proteinosis and the overlap with pulmonary fibrosis. I think a lot of people on the call will be aware of what pulmonary fibrosis is, and some with PAP, but not all with the overlap of the two, and how the two maybe intersect and how we can learn from both and potentially therapies for both. So my screen, hopefully everyone can see that there. Great. So I am a respiratory physician in Dublin, Ireland. I have a special interest in rare lung diseases, particularly interstitial lung disease and ultra rare conditions. So both of these conditions I treat and look after patients on a regular basis. These are my disclosures from grant funding and some consultancy work with different industry, but has no effect on the subject of this talk. So just, PAP, or what is pulmonary alveolar proteinosis? So just really to recap, because I think if we understand it, we may understand how to treat it, but also the relationship with fibrosis. This is a rare syndrome. It's not a specific disease, and it's caused by progressive accumulation of surfactant in the alveolus. So you get a buildup of all this material that's meant to be there to allow your lung to expand and contract normally. And your alveolus should be nice open spaces, but they get filled with all of this thick material of lipid and protein. And so do the cells in your lungs called macrophages. And these macrophages are meant to recycle this on a regular basis, but in PAP, they become foamy and stuffed and become dysfunctional. And this is one of the hallmarks. So this is what the biopsy hallmark looks like and the cellular hallmark looks like. And what this results in is a restrictive lung disease, impairment in oxygen exchange capacity, which leads to respiratory failure and death in very severe cases, but patients are often breathless and they can present with recurrent symptoms. There's three forms. There's primary, secondary, and congenital, and I'll explain those very briefly. How it presents is in a myriad of different ways, and what I'm showing here is they can have a chest x-ray that looks like pneumonia, it can look like heart failure, it can look like a non-specific interstitial lung disease, which can be differentiated between fibrosis or not. And you get lots of these CT patterns that can all represent PAP, some that are difficult to differentiate and some that have this classic, what's called crazy paving. And this is the classic crazy paving where you get these normal areas, which are these black ones indicated by my cursor here. And then you get this abnormal ground glass opacification, this grayish area with this interlobular septal thickening, these white lines which look like this crazy paving, this pavement appearance. So you get a normal, unaffected area with an affected area with this material that's built up and clogging the alveoli or the lobules, the individual sections of the lung. And this is the classic one, but that alone is not diagnostic. Other things can cause that. Some infections, sometimes with pulmonary edema secondary to heart failure. But this is not the only condition, but this is the classic appearance. But we think that's shifting a little bit, and there's other ways that it presents. How common is PAP? We did a study a number of years ago, and there's been similar studies in Japan and in other countries, but in the US, when I was working there with the PAP Foundation, we looked at the prevalence of this. We looked at about 15 million patient claim data set from the US, and it showed about 7 cases per million of PAP. And affects all ages, affects males and females equally, and it seems to increase in age, but I think this may be more of a diagnosis bias rather than actually prevalence. And it crosses all ethnicities and geographic locations. We think this is a minimum estimate. This is definitive cases, but there's likely underdiagnosis, and that's something that we think is present also. And the reason we think it's underdiagnosed is they've got very non-specific symptoms, and you've got these CT findings that are abnormal. These are the symptoms that patients with PAP present with. You can see this is similar to pulmonary fibrosis, to many other lung conditions. They get dyspnea or shortness of breath, fatigue, prolonged cough, chest tightness, chest pain. So these are classic, common symptoms that you see in any pulmonary or respiratory clinic. And so it's very difficult to discern this. One thing that's helpful is when you do a bronchoscopy, they get these classic foamy cells, this milky fluid. It's not diagnostic, but it's very indicative or helpful. But again, you have this broad differential pneumonia, heart failure, these other pneumonitis or interstitial changes, and then down the list, you come to PAP. So how do you get to that diagnosis? Well, understanding the causes allows us to make a clear diagnosis. So PAP, we talk about primary, which is a disruption of GM-CSF, which I'll explain in a moment. Secondary or congenital. And essentially in secondary, it's anything that affects your alveolar macrophage, those cells in your lungs, the number or function. And things like certain hematological malignancies or disorders can cause an abnormal cellular function or number, and then they can't behave properly, and that's what causes this buildup of fluid in the lung. There's other inhalational injuries that can do that as well, certain toxins like indium or other metals. And then very rarely there's congenital, where individuals are born with a mutation affecting the production of surfactant or how it's handled. But the vast majority, about 95%, are primary, and most of those are autoimmune, where there's an antibody against GM-CSF, and occasionally there's a hereditary form where the GM-CSF receptor is missing. And how we understand this, so not to labor too much on the science, but it's important. GM-CSF affects how your macrophages behave. And what happened was 30 years ago now, a group studying a mouse deficient in GM-CSF to understand how blood cells are regulated from the bone marrow. They knocked out this protein. They knocked it out in mice, and they noticed that the mice developed the same disease. So this is a normal wild type mouse. This is what healthy lung looks like here in the middle. These big open air spaces where oxygen can get in and exchange across that thin layer into the lung, and then across that into the bloodstream. And in patients with PAP, you get this buildup of all this foamy, lipid-laden material, all this protein and lipid, and it's blocking it. It stains for surfactant, which is this brown stain. And as you see here, this is the mouse where this GM-CSF is knocked out. They get almost an identical pattern to the humans with this PAP syndrome. And the macrophages, these cells are foamy, they're full of this red lipid. And so the fluid is similar as well. So it's very serendipitous that this knockout mouse said, well, maybe GM-CSF is the problem. Because beforehand, most of these cases were called idiopathic. We didn't know what caused it. We said patients had PAP and we've no idea. So a group in Japan then following this study went and looked to see, is there antibodies against GM-CSF present in the fluid of the lung of these patients, and then subsequently in the circulation, in the blood. And they did, they identified this. So the hypothesis was these antibodies cause PAP, and that's been proven. When you look at these idiopathic cases, they were the only ones with the antibody compared to these other known causes like a secondary malignancy. Then Bruce Trapnell's group, 20 years ago now, purified this antibody, and then they inoculated non-human primates into macaque monkeys. They showed that if you introduce this antibody, you can affect the signaling in your blood, the cells become abnormal, and then you get the buildup of that lipid and surfactant in the lung. So this proves that these antibodies aren't just a diagnostic tool, they cause this disease. Why is that important? Why is it important to understand? Because now we understand the biology of what we need to target. So just to briefly summarize, in your lung, you have these cells, these type 2 cells that create surfactant, and surfactant is really important. So they create it, and about 50% of the clearance of surfactant is done by those same cells. But this big orange cell here is your macrophage, and it's meant to gobble this up and eat all this lipid and recycle it. So you need to recycle it or it continues to build up. They look after the other 50%. And what GM-CSF does is it controls this lipid handling and also causes these cells to mature, to become, grown macrophages that can adequately regulate this. But if you have no GM-CSF and you have these antibodies, what happens is it binds all this GM-CSF in your system. It doesn't signal through the macrophage. The macrophage becomes stuffed. It cannot cope with it. And all this surfactant builds up, and that affects how you exchange oxygen. That leads to this buildup of this white material, this lipid, this foamy, milky appearance. And then that happens on your CT scan where you get all of this material. And that happens for autoimmune PAP, as we call it now, where you have these antibodies against GM-CSF. And why that's important. So a year and a half ago, we finally published the first ever guidelines for this condition. And we now have what's relatively unique. When you see a case that you think may be this, the first test is to do an antibody test. And this is unique because there's no real lung diseases anywhere else that we have a blood test that tells you the exact cause of your lung disease. So that doesn't exist in IPF or most kinds of pulmonary fibrosis or sarcoidosis. So we have a blood test in this rare syndrome that tells us the vast majority of cases, which is really important. So you've got an abnormal CT scan and your bronchoscopy looks like that, or even without the bronchoscopy and your history fits with that, we have a blood test. So it means that we can diagnose these cases. And so we have an algorithm that shows that. So that's really important that you can diagnose this. And why it's also important is some of these CT scans, because they present a little bit differently, potentially some of these patients who present as a query fibrosis or a query interstitial lung disease may actually have PAP. Now, I'm not saying very many because this is a rare condition, but it's likely underdiagnosed. And the fact that there's a straightforward antibody test, if the CT scan is not classic for IPF or some other cause, it may be warranted to do a simple blood test to see if it's positive. It's a really sensitive. It's almost 100% sensitive and specific. So you don't get false positives in this test. So it's a very straightforward thing to do to test patients who have an ambiguous diagnosis in interstitial lung disease clinics. So just what I wanted to talk about now is this fibrotic PAP. And so when we did this task force, we spent several years working on this. We put together a lot of the experts in this area, and these were the future research needs. And not only did we want to get better biomarkers, but a couple of the things that came up really important were, who's going to need a transplant? And these are patients who progress, but what is fibrotic PAP and how can we define it? Because we do believe that it exists, that some of these patients progress over time to get fibrosis, but it's really poorly understood. And so what is it? So in the reports out there, it ranged from 5 to 10% of patients with PAP over the time would get fibrosis. Would get these CT scans that look like idiopathic pulmonary fibrosis or these progressive fibrosing ILDs where you get this honeycombing, loss of lung parenchyma. It's less of this material building up and you get what looks like destructive lung disease. And the question is fibrosis related to the GM-CSF signaling, to the buildup of the material that's in the lung, to the dysfunctional cells that are there, or is it related to treatment? Some of the treatments, the washout that we do, these lavages that we wash out the lung, or some of the experimental therapies that have been tried for a number of years. And what I haven't shown, just in the interest of time, is there have been a number of trials that show GM-CSF inhaled therapy works really well in these individuals. So inhaled therapy works. And so the question is, who are you going to give that treatment to? And maybe that's something for debate here. So we've done a study recently about how common is this, what causes it, and then the question is, should we treat this earlier in PAP, and does that have other added benefits in other diseases? So this is a very short study I just want to show you. We've done this in just over 70 patients. We've this up to about 100 now, but the data I'm going to show you is in just over 70 patients from patients with PAP from Ireland, France, Germany, and 2 centers in the US. And 50 patients had longitudinal imaging. And we looked at the CTs by radiologists. So We graded this about how severe their pulmonary alveolar proteinosis was, and we looked at their fibrosis. So everything from the septal thickening, the crazy paving, and then we looked at honeycombing, traction bronchiectasis, and other things that are associated with different markers of fibrosis. And we quantified this with a validated score, and then we looked at the distribution, and we wanted to see how this changed over time. So just very briefly, we had approximately 50-50 male-female. We had 70% were ex-smokers, which is common in PAP, that there's some relationship with smoking. And they had a range of different treatments. The vast majority had a lavage, which is a washout, and only some of them had experimental therapies, about a quarter with GM-CSF, which is still off-label and will possibly get a label later this year, both by the FDA and EMA. And the reason I want to show these CT scans is, going back to my earlier slides, I showed the classic CT findings. But when we go and look at 100 consecutive patients, or in this case, it's 75 for the beginning, scans, you can see they don't all look the same. Some of them you could be said, this is kind of the sparing. This one could easily be mistaken for a different fibrotic lung disease, as could this one in the middle. So these are all different types of looking scans. They don't look classic. You can see how these could be in lots of interstitial lung disease clinics. So we had, and the interesting finding that we found is, in terms of the ground glass classification, about 2/3 have crazy paving, the classic finding of PAP. And all these patients have confirmed autoimmune PAP from expert centers in this rare condition. These are all 100% sure of what the diagnosis is. And you can see here, 2/3 have crazy paving. But surprisingly, a quarter had traction bronchiectasis, a classic progressive fibrosing phenotype. And 13 to 14% had honeycombing. And honeycombing we associate with progressive fibrosis, with fibrotic ILD. We don't associate with PAP. We don't associate it with inflammatory conditions. This is established fibrosis and irreversible. And when you look at the overall percentage that had evidence of fibrosis, 27% had fibrosis, and it affected about 11% of their lung. And that's all patients in the 73 here. But interestingly, when we went back and we looked at the 50 patients who we had longitudinal scans on. So we had 50 patients. Again, they were similar to the 73, and the follow-up was very long. You can see here the mean follow-up was about 38 months. So 3 years follow-up. So it's pretty good. It's a long follow-up. We're pretty confident that we have a long amount of time. Now, obviously, there's a range here. Some are longer. But when we look at this again, similar baseline, 14% with honeycombing. But after interval, that had increased to 22%. Traction had gone from 24% to 38%. And the percentage of ground glass, this kind of soft material, this lipid building up, had decreased over time. So we believe the natural history in this small group is that over time, a lot of patients progress to fibrosis. So that you have this PAP phenomenon, whether it's treated or not, and we looked to see it wasn't related to what treatment they had, whether they had a lavage, whether they had rituximab, whether they had inhaled GM-CSF. And you can see the percentage of fibrosis increased and the number of patients. So it went from a quarter of patients, 26%, up to 40% of patients over that period, over a mean period of 3 years. So, and it affected over 28.5%. So this is not only more patients, but more of the lung affected as well. So we think this is beginning to show, we're continuing to study, we're building more data from more centers, longitudinal, trying to reduce down any bias and reduce down any confounding factors. But we think this rare condition does develop fibrosis over time, and where it is, we want to know. And I just want to show a couple of scans. So this is a scan of classic crazy paving in a 59-year-old male, and then 116 months later, so 10 years later, this is the scan. And you can see here this subpleural fibrosis. This is kind of subpleural honeycombing here. This is a classic IPF type pattern, or certainly a progressive fibrosing ILD. Similarly, this man who has approximately 7 years of follow-up, 64-year-old male, again, this PAP kind of more ground glass changes, some sparing, doesn't look fibrotic here, and then develops what looks like a classic fibrotic ILD here. And this is over time. So it does progress. And then the final one here, just to show again, a younger man over a shorter period of time. Again, it's very inflammatory. They have this what's called subpleural sparing in PAP. And then you can see they get clear traction bronchiectasis, these long tram tracks as they're called. And you get some honeycombing. So again, This is again over just a 2.5 year period. So this condition does put you at risk of developing fibrosis. And so again, just to recap, 27% of the patients had fibrosis at baseline. That increased up to 40%. And when we went to see, and this is what we're continuing to work on, is the where you get fibrosis is that where the same material builds up, and it looks like it. About 89% of patients who had fibrosis or new or worsening fibrosis corresponded to where this ground glass buildup of surfactant material was. And we're beginning to analyze that. We've done some initial work where you can see the more affected lungs get more fibrosis, where the red corresponds with those areas that are more involved. So the more ground glass opacification you have, the more fibrosis you ultimately will get. And you can see here that also associates with outcome. So if you get fibrosis at baseline or progress over time, your probability of dying or needing a transplant has increased in this rare condition as well. So these are poor indicators of survival as well. So really the question, and I suppose some of the discussion points we want to have is, what is the risk? We're beginning to understand that a little bit better. But one of the questions is, should we treat early, regardless of symptoms? And then one of the other questions to really discuss is, in the fibrosis or ILD world or ILD clinic, should we be screening for this condition? It is rare. We're not expecting most patients to have it, but you potentially have treatable traits where we can remove this or treat the disease early with inhaled GM-CSF or potential other novel therapies. So I don't want to talk too long. I want to have a discussion because I think that might be more helpful. We could talk all day about a lot of these conditions. So I'm happy to take questions and hand back to Kelsey and Jen for chairing the questions. But that's just a little bit of data on a rare condition that we think we're beginning to understand more of the fibrosis.
Thank you so much. That was a wonderful presentation, very educational. And so I appreciate that. Well, let's open up to the floor in a Q&A. We have a question from one of our guests. They ask, is age or prior exposure to airborne toxins a possible contributor to develop PAP?
Age is not a contributing factor. Certainly it appears to occur and can occur at any time. First diagnosis may be in your early 20s or 30s or in the 70s, and we've seen patients like that. So age certainly doesn't seem to be a contributing factor. Certain exposures are, they're rare, but we do know there's an association. One of the emerging ones or re-emerging ones is really silica, because as silica begins to be mined again with modern technologies for things like smartphones and some of the other things that silica is being used for, we're seeing an increase in silica proteinosis, where if you inhale silica, it causes a dysfunctional macrophage. Just like if you knock out GM-CSF, your macrophage can't function properly. And if it's full of silica, then it can't clear the lipid. And so that's how silicosis or silica proteinosis can occur. And we know that silica causes fibrosis as well. So the two we think are intertwined. But there are some other rare things like, certain titanium and indium where it's been reported that if you're mining these, but generally we don't think it's, the primary thing. We think it's probably in patients, even in autoimmune patients. Certainly there's a higher representation of people who have an environmental or dust exposure, but then they also have the autoantibodies. So whether they're prone to it because of the autoantibodies and then the dust causes that to come to light is more likely than the dust itself causing the antibodies. But it's hard to tease out that. But generally, the dust exposure causes a secondary dysfunction, and the classic one is silica and indium.
Yeah, that's what I was going to ask. If that more the exposure would be is more secondary PAP versus autoimmune. So yeah, that makes sense.
Right. I also think about military exposures, right? We think about, what our veterans across the world, right, or what they're exposed to. So that's something to be thoughtful of, I guess, right, with dust exposure and any type of
Certainly, potentially this condition, if you disrupt the normal cell compartment in your lung, and if that's kind of toxic gases from some sort of military exposure as well as dust, there's no reason that potentially cannot cause that. And that's kind of a diagnosis by exclusion, because if you get this type of condition, like I showed, 90% of these cases are autoimmune. So we can test that with a blood test. It's really straightforward. So even if you have a dust or a gas exposure, the first test to do is this antibody test, because it's a blood test. and it's really sensitive and specific. And if you are above a certain threshold, so it's important to note, just saying that presence or absence of antibodies is not enough. It's above a certain threshold, and that's done in certain labs, worldwide. Not all labs, but certain labs can check the level of it, and above a certain level, that is diagnostic. So,
Right.
so even though potentially yes, any exposure, especially a prolonged exposure, may disrupt, that cell compartment, then
Right.
it could certainly be in veterans or anybody exposed to those kind of difficult gases or fumes.
Great. Thank you, Dr. McCarthy. What should patients do if they think they've been misdiagnosed?
Um, you mean if they think they may have PAP and they've been misdiagnosed as some other condition?
Right, right.
I think well, they probably should say it to their physician, but and they should ask to be tested for the blood test. Doing so I didn't have time, or I didn't want to spend too much time showing, an hour's worth of data, because I don't think that's necessarily helpful. There's too much. But for a long time, patients with PAP would have received a lung biopsy, and actually a disproportionate number. And we've made a strong recommendation that this should be really the final test when you've exhausted all other avenues, because it's not helpful. It
Hmm.
just says if PAP is there, but it doesn't say what the cause is. So, a lung biopsy won't help. So actually there's blood tests, there's the antibody, there's also these signaling tests, and there's genetic tests that can be done. So I think if somebody thinks that they may have PAP and they may be diagnosed with that, and the common one that we think is probably missed is when people get told they've HP or hypersensitivity pneumonitis, because it can look like it has this kind of waxing and waning interstitial changes or ground glass. It kind of may get better with some treatment, or they treat infection for a while. So we think that one may be misdiagnosed more so than something like IPF.
Hmm.
And it's
Mhm.
asking for the blood test, because the blood test is minimally invasive, not cumbersome to a patient to wait for a blood test to be done and sent away to one of the laboratories. And it'll give your answer in 90% of the cases of PAP. So, like most
Hmm.
people with PAP have autoimmune PAP. Actually, and most adults with PAP will have that, because the hereditary causes, the congenital ones, are often picked up in early childhood. So, if you think, it's really the vast, vast majority of adults will have autoimmune disease.
Yeah, as an autoimmune PEP patient, I also did not go down the lung biopsy road. I was like, there's no way. And fortunately, I was able to find out information on a blood test through PAP Foundation. And so that's where I got my diagnosis. And I agree with you, Dr. McCarthy. The lung biopsy is a no-go. Go with the blood test, definitely. So yeah.
Yeah, yeah, no, you're lucky, Kelsey, because we did a study a number of years ago where we looked at patients in the PAP Foundation registry. We had about 100 patients, and 80% of them had a biopsy. And most of
Yeah.
those patients had autoimmune PAP. Almost everyone we looked at had autoimmune PAP. And about a
Yeah.
third, or just under a third, of the patients who had autoimmune PAP had a biopsy that didn't even show PAP, because the patchy nature of this disease is one area of your lung is totally normal, and the one corresponding to it, like right next to it, is affected. And so it's not a diffuse disease that way. It is patchy, where totally normal beside totally abnormal. And so the biopsy may miss it. And that's not the surgeon's error. It's just the nature of this condition. So so a biopsy is not what we would recommend. So certainly if someone thinks they may have it, doing the blood tests is certainly helpful. You'll rule out a lot of things.
Oh yeah, 100% agree with you on that. Let's see. We got a couple more questions. So are there any emerging therapies on the horizon for either conditions?
Um, for PAP or for fibrosis, because there's a lot of emerging
Both.
therapies for fibrosis. So
Yes.
obviously in pulmonary fibrosis, it's a growing area. There's successful trials. The Fibroneers trial was a big readout last year, which shows that nerandomilast is an effective therapy available in the US and coming to Europe, we think, later this year. But and then there's big results with Teton IPF, another really positive trial result with treprostinil, a drug repurposed from pulmonary hypertension. So in certainly in the pulmonary fibrosis or the progressive pulmonary fibrosis and IPF world, there are going to be, 4 options soon, and potentially more. There's other trials ongoing. So that's a growing world. So certainly when it comes to fibrosis, there's growing options. Whether they work in PAP-related fibrosis, that is a rare condition with a rare subtype. So that's unknown. I have used antifibrotics in some of my PAP patients who have progressed to show fibrosis because they were behaving more like a fibrosis patient than a PAP patient in terms of the way that they were progressing rather than the waxing, waning ground glass. And that has delayed progression in one. The other, it's difficult to know. It's been too short a period. But again, we have treated like any other progressive fibrosing disease because regardless of whether it was sarcoidosis or connective tissue disease, the data says, well, if you progress with fibrosis, you may respond to these treatments. So I think there's an emerging area there. In terms of PAP, the Impala 2 study was published last year. That was a phase 3 inhaled GM-CSF trial. It showed that it met its primary endpoint. It showed that it improved lung function in patients. Patients with fibrosis on their CT scan were excluded from that study. Patients with a lung function very, very low were excluded from that study. And patients with totally preserved lung function were excluded. So you were looking at it, and that's for study design. It's important because you want to be able to show efficacy in a defined group. But what we don't know is, how it'll affect people with early disease. Does it prevent the disease ever progressing to fibrosis? So there are questions that need to be answered because the study looked at people with established PAP with abnormal lung function. So, and that looks like it will possibly, it's going to be discussed at the FDA and hopefully get FDA approval soon, and then subsequently EMA, and I think it will. And so hopefully then that will be, drugs. In terms of other therapies, there are other ways. There are a number of emerging, they're much earlier stages. We think the common mechanism for these conditions is this abnormal macrophage, that if your macrophage is abnormal, can it cause fibrosis by signaling to other cells in the lung to cause destruction of the lung, to cause extra collagen to be deposited. And we have evidence from mouse models where if you affect the lipid handling capacity, which is what happens in PAP, that can cause fibrosis as well. So we think the two are interlinked that way. And there are some emerging cell therapies or small molecule therapies that are affecting how your lipid is handled by your macrophage. So that may be an effective therapy for both, but it's very early stage to say that they're a common therapy. The one caveat, so the reason patients with some fibrosis or an element of honeycombing were excluded from the Impala trial is there is a hypothetical. So GM-CSF works on macrophages to make them function. There's data that GM-CSF on fibroblasts may make it more pro-fibrotic. They may drive fibrosis in certain models, certain animal models, certain cell models. So the idea to give GM-CSF to a patient who has fibrosis, none of us have yet figured out is that, comfortable. So should it be that you give it only to patients who have no fibrosis like the study, or is it that you give it to patients who have a minimal fibrosis and mainly the kind of surfactant buildup? So we don't know if giving GM-CSF to autoimmune PAP patients who have mainly fibrosis will be effective. It may be detrimental, and that is not yet defined, and there's no data for that because of the studies. So that is the one area, and it also raises the question that there are other trials coming in PAP. There's trials coming at looking at targeting the antibodies directly, not rituximab. That's been done before, but there's new trials hopefully at looking at binding the antibodies. And maybe that's a treatment that's helpful for the prevention of fibrosis or patients who already have fibrosis. Instead of giving GM-CSF, maybe a different therapy that binds your antibody might be a treatment for those patients who have fibrosis and PAP. And, so it's, there is definitely room to get more therapies here, but I think it's at least exciting that there's a number of industry partners who are at least kind of looking in this area or beginning to look more in this area, which I think is encouraging.
I think
that's sorry, Jen, go ahead.
I think a great part about this webinar is bringing all this awareness about the connection here. And so, and a lot of questions folks might have of how do I approach our provider, your provider, to take a deeper look in testing for either PAP or PF? And what are your thoughts about what that would look like, and what would you suggest? I think having a blood test for PAP is, mind blowing, right? Of being able to have that disease diagnosed through a blood test. So
Yeah.
what would you suggest of really how to approach that as a patient, as a care partner,
How to approach kind of
to have that
the
conversation of the PAP and or PF?
um I think the way to approach it really is you have to still remember that this is quite rare, so and that's not to say that it shouldn't be tested for, but I think if something doesn't fit, so a lot of if you look at pulmonary fibrosis and the way multidisciplinary discussions have changed over the last 10 years, there's good data that the number of IPF cases is going down and the number of these kind of PPF or unclassifiable ILDs has gone up. And that's because we've loads more information. People may have, you know, they present at different stages. Their CT scans look a little different. They're not kind of these burnt out, IPF end stage lungs that we classically saw 15 years ago. So I think if a patient has some of that ambiguity that isn't, barn door slam dunk IPF, I think then it's no harm to say, okay, what do you think this is to the provider, to the physician, and say, you say this is kind of not IPF, it's a progressive ILD, or it has kind of progressive fibrosis, you say it could be X or Y, or it's unclassified. And then it's very easy to say, would you consider at least checking for PAP with this antibody test? It's a blood test. You can send it, depending on which country you're in, there's central laboratories that do it. If you're in the US, they can send it to Cincinnati or Denver. If you're in France, they send it to kind of Rennes. There's different centers in Europe and there's different centers in the US. And we put that all in the guidelines, actually. In the PAP guideline document, we put which exact centers to send the blood test to. Mm-hmm. So I think that's how, if I were a patient who was, given this slightly ambiguous label, it may be worth asking the question. Mm-hmm. Because I think that's, and especially in these patients who have a combination of maybe some fibrosis and some inflammatory or some ground glass or some of this, indeterminate CT findings, then it's worth at least asking the question. It's not a difficult test to do. And if it's negative, it's probably not PAP. It's very, very unlikely to be PAP if it's not the antibody test. You may not need to go down the route of doing all these other complex signaling and genetic tests that are part of the PAP workup. That's if the patient presents classically and has the foamy, milky fluid. But if they don't, the antibody test might be enough. And if you pick up this disease, then there may be an element of reversibility with a lavage or with the inhaled therapy. So I think that's how I would approach it. It's if it's not that slam dunk barn door IPF, there's no harm in saying, was this considered? Could I have the antibody test? It's not hard to do,
Actually, leading up to this, we have a question. So this is a PAP patient. They said that their in most cases, what is the prognosis after an alveolar lavage? They state that they have a patient, 24 female, needing lavage every 3 to 5 months with a lot of buildup. And the sargramostim treatment helps, but is not readily available in their country of India. What are the solutions can you give them to approach for management of PAP?
Yeah, it's a great question. And so to the first question about like the long-term effect of lavage, it is highly variable. The data shows that it's the median interval between lavage of historical data is about 15 months, but that varies from having one whole lung lavage in your lifetime to having one every 2 months or so, like this individual that they're describing. And so there's huge variability, and we don't fully understand who's going to be a responder. We don't know that if you wash out your lung, will they respond and never need another one, or need one in 5 years, or never need one again. And certainly that seems to be a case-to-case basis, depending on the underlying cause. So if this is an autoimmune patient who requires whole lung lavage, it's likely that they would benefit from inhaled GM-CSF. But obviously that's not readily available. It's highly expensive because it's off-label in a number of countries. It's off-label everywhere except Japan, actually. Japan is the only place that sargramostim is currently approved. And so it's extremely expensive and off-label, so difficult to get. So the options to that are either to seek a provider, one of the companies who makes this, to give it as a kind of for free, which occasionally they do. And certainly we're happy to connect any provider with the companies, because we've done that many times where we say, especially in a country that it's difficult to access or the cost is prohibitive, to say, can we have an early access, or can we have a kind of compensated version of this, where it's, the company often will provide that free of charge in certain cases, and that's certainly as they're developing a drug, that may be the case. So that's it. There are other experimental therapies that we talk about in the guidelines, like plasmapheresis and rituximab, but they generally don't work. There's not enough data, and usually there is a last line of defense that someone who's critically unwell in an intensive care setting on a ventilator. There are other off-label cheap things that we do talk about briefly in the guideline with minimal data. We use, for example, statins, which treat high cholesterol. We have data from mouse models and mechanistic models that this may be useful. They're certainly cheap and safe and widely prescribed for millions of people worldwide. So we don't think there's much risk in giving it, even though the data may not be supportive. We have some data to show that they work. Similarly, there's some other diabetes drug called, PPAR gamma agonists, things like rosiglitazone and pioglitazone, which have also been tried in pulmonary fibrosis. This is where we come back to targeting that macrophage. And they're, again, cheap, safe, and we just haven't had the ability or the funding to do a trial in these, kind of repurposed cheap drugs. And so using those, there may be minimal harm and some benefit, or maybe maximal benefit. And so that's, what we would generally do. But some people, unfortunately, are lavage dependent until they get regularly on GM-CSF.
Yeah. Yeah, that's definitely a challenge. You don't know if you're going to be a slow accumulator or a fast accumulator. So we're all kind of in the same boat, but we have a different version. So this maybe is piggybacking on, and we might have already answered this, but have any current medications for PF proven helpful in PAP? So you kind of touched on that a little bit, but
the word proven, well, then the answer is no, because there's no studies. There are some anecdotal case reports that have been presented at conferences. There may be one that should be published soon. It was being reviewed, just a single case. But again, there's no proof. I suppose we would treat them where you do this lumping, progressive fibrosing ILD. If they have the pattern of CT scan, like I showed for some of the examples of those 3 individuals where I showed that those scans now look like fibrosis and they look like they've progressive fibrosis. So whether that was scleroderma, hypersensitivity pneumonitis, kind of sarcoidosis, a lot of those patients got included in a lot of the progressive fibrosing ILD trials, whether it be Fibroneers or InBuild or any of the prior ones. So you could say that, look, there's evidence for progressive fibrosis. So from that perspective, there is evidence, but not specifically in PAP. There's no proof that they work. But I would not be afraid to use these antifibrotic therapies. The question then is whether to stop GM-CSF if it's predominantly fibrosis, because continuing GM-CSF, and if it's mainly a fibrotic phenotype, that's an unanswered question. It's one we're trying to hopefully get data for.
Yeah, no, that's great. So then they're asking, are these therapies mostly in the US or can they be found globally? I mean, I think you kind of touched on that, but
I touched on, and I suppose technically whole lung lavage is available globally, but some centers do it frequently and they do it better. And it's not that they're better physicians, but if you do any procedure frequently, just like, anything in the world, the more you do it, then you should be more experienced at it, and especially for a rare condition. So some centers for whole lung lavage are really very experienced. And again, we talk about that in our guidelines, where when we talk about whole lung lavage, we have a clear point to say this should be discussed with an expert center, where we have a list of those available, and say that even if you can't access that expert center, at least get the advice of that person to be able to guide where locally or how to do that lavage. So that's certainly a thing. In terms of the actual therapies, sargramostim, which is the one type of inhaled GM-CSF, and molgramostim is the one that's currently looking for approval. Both of them are looking for FDA approval.
Mm,
Both of them are looking for EMA approval. They're at different stages, and I'm not at liberty to exactly give any further details because I don't have all that. And um, but once they become approved within certain jurisdictions, then they can be more readily available in those areas, and then it becomes a reimbursement question. But certainly in the
right.
US, Sargramostim is frequently prescribed off label and reimbursed by payers. That is a frequent thing that it's given off label, it's reconstituted by a local pharmacist and given off label as Leukine is the trade name there. So and that comes down to payers and the physician negotiating with the payer in the US system. It's obviously different in Europe. We have predominantly national payer systems where the governments then negotiate prices with the companies who make it, and when it's off label, it's almost impossible to get that. You have to negotiate, a different price. But when it becomes on label, which we hope in the next year, then in Europe, certainly that becomes usually a countrywide negotiation with the industry. So whether it be Germany or France, they negotiate a price and that's the price and it gets reimbursed. Um, but there's all slightly different systems. But then globally, as mentioned by the individual who has a patient in India, it is hit
Right.
and miss. It is difficult, and but there are potentially ways to look at accessing it. But then there are
Right.
cheap alternatives that may be minimally harmful and may be effective.
Right, exactly. Next question is actually for Jen and I. How do these foundations hosting webinars support patients and their families? I'll let you go first, Jen.
Wonderful. Yeah, I mean, through the journey and trying to navigate the diagnosis, first of all, right? It's very clinical, it's very medical approach to everything. But through this journey, to have that support along the way in educating oneself, not only the patient, but the entire family and the care partner, in trying to empower with this information to have these conversations. We just had a question about how do you approach your provider to ask about PAP, ask about PF, and so a lot of ways that we do this at Wesco Foundation for Pulmonary Fibrosis is through our support groups, and so we now help navigate folks who are trying to find a diagnosis, initially diagnosis or diagnose into transition to supplemental oxygen, lung transplant. And we serve our veterans living with interstitial lung disease and women living with the ILD. So we want to make sure there is not only the supportive care aspect of it, right? It's very emotional to try to find that diagnosis and navigating and living with it every day, but also in helping folks understand it again to have these conversations. And so it's not only the psychosocial aspect of it, the educational aspect of it, it's also having these conversations with folks who are walking in this journey. Not everyone is the same, it's very unique for each person, but in these conversations, we get so much information in what we call peer-to-peer connect and very open, honest conversations of what one is experiencing and really learning from each other. So that's a huge part of our programming. Another part of it is exactly what we are here today is expertise. Dr. McCarthy, we're so grateful you're here and educating us on both aspects, PAP and PF, and also having these dynamic questions and not necessarily conversations, but Q&A, right? And so the educational aspect of it is very important through, we have a podcast, Pulmonary Fibrosis podcast. We just launched a lung transplant podcast and understanding, right? That journey it's itself. That's a whole tangential, right, journey within anybody who is managing respiratory disease that leads into lung transplant. So we have such a privilege to walk with our pulmonary fibrosis community, and any resources that we have offered on our website, WESCO, WESCOE.org. Visit it, learn about pulmonary fibrosis, but all the incredible resources. We are very collaborative organizations. We are so grateful for Kelsey, PAP Alliance, and being here today. And this is what it's all about, really that collaborative effort in supporting our communities. So that is what we do in helping folks along this way. And we're all in this together, right? And so, you know, we're here to help every step of the way and reach out anytime. Kelsey, I'll hand it over to
Thank
you.
you. Um, well, Jen, phenomenal. Thank you so much for sharing all that information. And we're always so grateful to you. And I know that all the patients, families, and everyone, you take care of a lot of us. So we're grateful for that. Yeah, we're similar in the same sense as Jen. We have a lot of educational materials on our website that you can go to. We have a lot of resources. We list a lot of doctors throughout the globe that do treat PAP patients, and so that you can access that. We do blogs with other patients. So we like to really share the stories and share kind of what each of us individually have gone through, because as Dr. McCarthy has said, we're all kind of different. We may all have the same disease, but we all have different kind of, roads we've had to travel to get through this disease, to get diagnosed. There's a lot of information about how to get properly diagnosed, what to ask your doctors. We also host a lot of support groups as well. We do a support group every other month, and anyone is invited, patients, caregivers, please come. We want to open door. We want to be able to provide you with just having that one-on-one contact is so huge. When I got diagnosed, I was very alone in this world because 7 in a million is pretty small. Thankfully, I was able to meet a couple other PAP patients, and then we kind of got connected, and this is where we rolled out. So I really started the PAP Alliance to ensure that, nobody's left behind, nobody's alone, because I think it's so important that you find your community when you get diagnosed, because that's just kind of where you feel like you finally can fit into a proper place. I have a lot of meetings with fellow patients, and we always walk away and go, gosh, it's so nice to have a conversation with someone that gets it.
Yeah.
So that's really kind of what we're trying to do. Just build out our community, provide you all with any information you have. I am literally an email away. You can go to our website at papalliance.org, or you can also email Kelsey at papalliance.org. I'm happy to help you in anything. So don't hesitate to reach out. But yeah, let's go. We got a couple more questions, and then we're getting close to the witching hour, so we probably need to wrap this up. So we have one from a patient. Sorry, reading through. So it looks like there are, okay, this one was about a peer support group that they're looking for in India. Yes, that is absolutely something that we can reach out to. For this individual in India, if you know of anyone else in Indiana, please get them in touch with me, because I don't have a lot of connections or patients in that country. But yes, that's something we definitely can look into. Lastly, I think we're wrapped up. I think we got all the good information out there. So, first off, Dr. McCarthy, thank you so much for your time and presentation. It was so enlightening and educational, and we really do appreciate it. We appreciate you fighting to fight for all of us. You are a godsend. You are an angel on earth. So we're very grateful to you. And for everyone that's attended, just let you know, we will have a link and resources that we discussed on this, and we will follow up with those via email. So you will be able to revert back to that and see if there's any questions you might have. And of course, don't hesitate to reach out to either Jen and I. We are happy to help in any way we can. So yeah, thanks, Jen. Appreciate it. It's been
Kelsey.
wonderful.
It's been wonderful.
Yes. So, all right. Well, we appreciate it, everyone. Thanks, Dr. McCarthy. Thanks,
Thank
Jen.
you.
Thanks
Thank
for
you,
everyone
Kelsey.
to
Thank you, Jen.
attend.
Thank you.
Thank you, Dr. McCarthy. Take care, everyone.
Bye, everyone.
Bye.
Bye-bye.